Perfect. So thanks for having me, for this chest section. We spoke yesterday about PET and the GU, so excited to be here. So this one's on pulmonary emboli, a core topic. We're going to go through some key things we need to know, imaging, pitfalls, associated findings, etc. And, I think the main point here is, we don't need a lecture for the basic classic PEs, right? A central filling defect. Once it gets larger, once it's branching out, we don't need a lecture for this. I think we all got it, right? The obvious ones are easy. A perfect normal study are easy. The reason to make a lecture are cases like this, right? What is this messy vessel here in the middle, right? When we see these sort of sloppy images, we don't know what that is, a small, medium vessel. Either it's not a PE, right? It's just some sort of artifact, it's motion, it's bad contrast, or usually the ones we get tripped up are small. It's something in a small vessel and maybe it's real and we're seeing it poorly. The issue is, particularly if isolated, some of these tiny PEs probably aren't causing issues and then maybe even don't need to be treated. It's sort of a debate. So these, maybe could be left alone, especially if we're not sure. And of course, we all know that if we're going to treat a PE, you get a long course of anticoagulation. We have real risks, right? It's a big deal to treat. So this is my message. When we are doing PE imaging, maintaining specificity, not overcalling, is the most important thing to help our patients. So how do we not overcall? How do we be specific? We need to know the characteristics that are almost always present for PE imaging to be specific. So let's go through those. Here's a list for you. These are the ones I use. PEs should be longer than wide. They should be clot density. Sounds obvious, but they should be in an artery and not a vein. This is a good one. They should be oriented along the course of the vessel. I'll show you some examples. And then here is my favorite. You should remain convinced if you switch between soft tissue and lung windows, you should still think you're looking at a real PE for you to call it. Oh, thanks a bunch. So those are the lists that we're going to use, those rules. Let's go through some pitfalls and see how those rules apply to show how we maintain specificity. So here's our first sort of pitfall case. We see a pretty nice looking medium to small vessel. Contrast goes away. One slice later, it's back. So this happens, right? What rule does this violate though? If it just shows up on one thin slice, it's not longer than wide, right? There's just something that happened on that image, processing or motion or something. Violates that rule. One slice of low contrast, not a PE. Okay? As opposed to this, we're scrolling in a larger vessel, we see a filling defect still there. That is now longer than it is wide. It's a worm shape. So that follows the rule, that's a PE. Now the tricky ones are something in between. Here's a very small vessel with contrast, goes away. And we keep scrolling, it stays away. So this is longer than wide. It is a PE, but this is tough, right? You have to be staring right at that vessel as you're scrolling. This is why we recommend reformats, so you can catch these cutoff sides in small vessels. All right, pitfall 2. Off the hilum there, we have a medium to large vessel. Looks fine. We scroll, and the next image, we see a filling defect. It's eccentric. That can happen. So maybe we got a PE. We scroll one or two more images, and now it's on the opposite side. Okay, so we're already violating some rules here. But it still sort of looks like a filling defect, so it makes you wonder. And then we get over here, one or two more images. This isn't a lot of pictures. Back to normal. Okay, what rules have we violated here? It's a pretty big vessel, a pretty big filling defect, but only shows up on a couple images. It is not longer than wide. And it started off on one side, went to the other. So this is that rule that it should be parallel. It should be along the course of the vessel. This one's going diagonal. So it's probably not a PE. But of course, we'd like to know what it is. So this is where we follow to my last rule, right? So there's the soft tissue. And now I'm showing you lung windows. My favorite thing, right? Go back and forth and see if you're still convinced. So in lung windows, here I'll copy that vessel off to the side. But what do we see on that bigger picture? Yes, we have a medium-sized vessel, but you can actually see a ghost of that medium-sized vessel next to it. You can see a ghost of the airway right next to the main airway. And then what's happening is there is motion leading to ghosting in that image. And then the parts where that vessel are still in both ghosts shows up in the middle, and it's lower density on either side. So this is that last rule, an example. If you switch back to lung windows, we have now an alternative diagnosis, so we don't think it's a real PE. All right, next. This looks like a filling defect on that left image. It is violating some rules, though. It's not going parallel. And if we show it on lung windows, we can then see the airway has the exact same shape in just one or two images above or below. So this is volume averaging, and hopefully we don't see much of that these days. This is why we want to have thin sections for PEs. We introduce artifacts if we have anything more than the thinnest sections we can do. So again, the PE, you should remain convinced even by going to lung. We don't find an alternative explanation. All right, pitfall 4. So here's a medium-sized vessel. Doesn't look like it has contrast to me. Scroll a little bit. Contrast is there. So this is, since it's on the edge of the vessel, this is again volume averaging, but not with an airway, but just with the lung below it. And again, thin slices. Hopefully we're not getting this on the edge of vessels anymore these days. This one still happens some. So here we see two vessels, a little bit brighter on the outside than the inside, looks like a donut. But you might notice this is not our standard PE, right? The bone, the spine looks a little bit different. And that's because this was an image with edge enhancement not intended for a PE study. But if you do this for bones or other reasons, you make the edges sharp, it will make the edge of vessels sharp and actually can mimic having a PE. So the same image with normal standard soft tissue reconstruction, you don't have that edge artifact. All right, pitfall 6. This looks like sort of a low density filling defect. Continues there, continues there. What's the problem with this one? And every time I ask, somehow people figure this out with like 3 pictures. It's in a vein. I almost always have to scroll. But here it has the appearance of going towards the atrium. And this is a apparent, maybe, it's probably not, a filling defect, but in a vein. So it's not a PAE, and we don't care. And this was venous streaming. This happens a lot on the venous side. See a streak of low density. And in fact, on this bigger image, we even see why. There's a mass, so something is slowing down the blood circulating back, coming through the venous side. All right, pitfall 7. Definitely this is in an artery because it is connected to the main pulmonary artery, but we see some low density there. What rule would this violate so we know it's not actually a PE? If we measured it, that would not be clot density. I know it looks low, but it's actually probably well over 100, 150. And so this is mixing that happens within the main pulmonary artery or some of the bigger branches. We can even see why here. Even on lung windows, we can see some of that mixing. And why? Because there's slow abnormal flow. This person has an ILD, so the arterial flow is not normal. Now, mixing is a really key sort of expert level topic in PE imaging. If you do a lot of this, if you get really good, you end up having all these quirky cases of mixing that you save over the years. So here's an example, and I'm just showing how hard and advanced this mixing can become. So this looks like a PE to me. It's eccentric, but it's, has low density. I think we'd have to suggest it's a PE. Couple things that are weird though. Its location is exactly opposite of gravity. And on multiple scans, it kept showing up. People said, oh, this person had a PE. but then they treated it, it didn't get better. They scanned again later, it didn't get better. It's a little weird to keep showing up all the time under all circumstances. There's also a reason to have abnormal flow of blood. This person also had an ILD. At some point, some sort of expert level person, was not me, but brilliantly said, hey, maybe this is actually a mixing thing. And so at some point added to a PE study a delay. It actually was homogeneous and filled in. And then this was slow flow and mixing because of that ILD. All right, pitfall 8. This one's pretty common, unlike those weird mixing cases. Low density, what's causing it? Right, it's the streak. It's all that contrast in the SVC. We actually try not to have this, right? We have a chaser of saline after our contrast. We want to time it so we don't have tons of contrast in the SVC. Now, actually, what I pointed at was a vein, so that was cheating. But there is an artery next to it. It still looks low density, and it's just the streak. This is actually my favorite streak case because, gosh, that looks really essential. But if you sort of look on lung windows, you follow the streaks, it again is just streak artifact. All right, case 9. Remember, this one's been pretty tricky. We have low density, high density on the outside. Doesn't totally look like a normal vessel, though. It's not continuous high density. And what was this? It's actually calcification. I think we can get tripped if we go fast, but of course, if we look closely at the density, is it really contrast? Maybe if we had a non-con, or maybe if we look elsewhere in the mediastinum, we could catch those were just calcified lymph nodes. But if you're going fast, it could be tricky. And this one I actually remember when I was very early in my career. I was looking over someone's shoulder, they're like, what do you think? I was like, ooh, looks like a PE to me. But this is why you shouldn't read cases over people's shoulders. So, looks like high density, right? Looks like the same density as inside the vessel. Inside, smooth border of low density. But again, we actually see the same odd structures elsewhere. So in the subcarinal space, more there. And these were lymph nodes. And particularly renal is classic at this. Tumors on the outside, tons of blood flow, really intense contrast enhancement, and a dead smooth center. I don't know why it looks like this, but that's what happens and can really trick you. Here you can see a necrotic lymph node in the arch or in the sort of crotch of two vessels coming together, whereas here is a PE actually in the vessel in the same location. That's real. All right, next pitfall. Low density looks next to a vessel. Wonder if that's a cutoff sign, a branch of the vessel. But there are a couple things weird about it, right? One, it is unusual to have an abrupt cutoff that's at such a sort of acute angle, leaving the regular vessel next to it perfectly fine. And look how it has that lumpy, bumpy appearance. If we had the whole case, we would even see next to a contrast-enhanced vessel a low-density structure nearby, right? And arteries don't run next to each other as pairs. So it's something that runs next to arteries, and we see even a branching one there. And this is something in the airways running next to the arteries, because they do run together. All right, so for pitfalls where we practice our rules, we've gone through many, but we have left the most common and the least common pitfalls. What is the most common pitfall? Beautiful PE studies that look like this. I'm sure you've never scanned a PE study like this at your place, but it happens to me all the time. Is that a PE there? How about there? Are there 4 there? Maybe 12 over on this side? Who knows? This is the worst scan ever. It somehow happens all the time. So what is this? It's some sort of issue, right? It's contrast bolus, it's tons of moving, it's breathing, but it's called, something bad happened. I call it just the terrible scan. Unfortunately, a large minority of what we see. So what's going on? We got to get the people to stop breathing, stop moving. Maybe our bolus is bad, right? There are multiple ways to time a contrast bolus for a PE study, so maybe we should pick the other one. Does the flow from the IV to the heart have an obstruction? Are we going through an upper limb and there's an SVC obstruction, or some altered hemodynamic state? Okay, that's probably the most common. The least common. This actually looks like a filling defect to me, looks real, except it is attached to a mass a little bit lower. Here's a PET CT, here's a metastasis. So this is a mass directly connected to what looks like a filling defect, and it is tumor, so not bland thrombus in the vessel. And so that's the rarest, and we can go this to the rarest of the rarest. That's a filling defect, definitely in an artery. Looks real, but again, this is tumor, and this is a tumor that actually started in the pulmonary artery. Exceedingly rare, but another pitfall. All right, so we went through a bunch of pitfalls. The pitfalls are not the key. The key is the rules, the sort of patterns we rely on to maintain specificity. And again, longer than wide, clot density should be in an artery, oriented along the course of the vessel or parallel, and I switch back and forth to lung and remain convinced. Now, before we leave the imaging and going on to some controversies and other findings, I like to point out these two sort of reading tips. This is probably your standard PE window. I find it very bright. There's only so much so-so contrast. I actually like to read them starker, a little bit like think moving towards a liver window. It really makes PEs jump out if you can make it more contrast and less overwhelmingly bright. So I like this better. The problem is it is so much better and makes the clot so much more obvious, you sort of have to make sure you didn't fake yourself out and get mixing or some other issue. So I do actually switch back to the standard PE just to make sure it still looks the right density. If it's big enough, I'll even measure. But I really love those stark windows. And here's my other reading tip. This doesn't happen often, but I loved this. There's this terrible case. I thought maybe I had a PE because of this weird sort of rat bite out of that medium-sized vessel. But this was an inpatient, right? We had a fusion, we had a bunch of stuff along the vessels, probably some edema, opacity. And that rat bite bothered me, but you gave it a little bit more slices, and then it just looked like, I guess the branching vessel there. But then is that fluid? Is it a lymph node? Is it a PE? And here it looks okay. So I did not like the rat bite, but I guess the rest looked fine. But this is the first time I was struck with, hey, how do I know what vessels are there? And the answer was, I found some prior. Any prior with contrast. And then I found out, yeah, there's supposed to be a medium-sized vessel there. Something's missing. And actually, in a normal state with contrast, this person had two then vessels and one tiny vessel coming off, and part of it was missing. And if you keep scrolling on the prior, we should have two big vessels, and we are missing one. So I was now 100% sure I had a PE here, but I was not sure without the prior. So that is my last tip for the reading part. You can use priors, actually. All right, next, associated findings. People love to talk about these. So there's a couple of them. Instead of reading that list, I'm going to go through them with you together. The first is, when do we get worried about the right side of the heart? Now, the findings people talk about are these: big pulmonary artery. Now, this is double Olympic size. This is not normal. But, a big PA. We look for big right-sided chambers as evidence. People talk about reflexive contrast. Is that actually good? Here's actually a sort of rare one: contrast shooting backwards through the foramen ovale because of so much pressure on the right. So what do people teach us to do? They say, hey, look at enlarged either feeding vessels or right-sided chambers. Look for that reflux. Look for septal bowing, where the septum goes towards the left, which is sort of opposite normal. Or just see, is the right side really big compared to the left? How good are these signs? How good is the data? Not good, not good, not good, and so-so. So we learned this a lot, but I don't know it's a great, big, amazing sort of set of data here. So what do we actually do as humans with great brains? We take these sort of so-so signs and we sort of sum them up, right? Do we have one of them and it's small? Do we have lots of them and it's severe? And if you say how severe and how many, then we say, hey, I really think this is a case where the right-sided pressures might be high. We might have an issue. And that is really our only responsibility. Maybe we have a right-sided heart issue with this PEs, because after that we then diagnose with an echo and other people decide how much management we need. Do we need ICU? Do we need an intervention to actually fix it? All right, so that's right-sided pressures. Next is infarcts. We just saw some examples as fake-outs from infections in the last talk, and I have some incredibly underwhelming sentences to give you about infarcts. If you see wedge-shaped opacity when you have PEs, they might be infarcts. And then in fact, if you see wedge-shaped ones that you weren't thinking about PEs, maybe we should think about PEs. I don't know, there's a lot of maybes in those sentences. They're pretty weak. Why am I being so wishy-washy here? I think there's almost always a differential when we're debating this, infarcts. So here's a patient where they had neutropenia. They had signs of infection. They were totally sure they had infection. We had multiple opacities. What should that be? That should be infection. What was it? A random PE and infarcts on top of it. So this differential tripped us up. Or here is a case where actually we knew they had PEs. And that is almost as triangular as you can get. It just has a tiny little bit of the pyramid missing. That should be an infarct in someone with PEs, but actually not. It is an infection. So I've always been struck at how we cannot be 100% certain for this diagnosis. So I always remember there's a differential. Next associated finding is mosaic perfusion. So sure, we can see this with acute PEs, but we actually try to look for PEs, so who cares? The issue is it might come up with chronic PEs. Now, sometimes chronic PE, we actually saw a case in the last lecture, they can be big, eccentric, obvious. That one's easy. That's easy. We could maybe catch this vessels getting bigger and smaller. The problem is they can get pretty tough. You know, this one is totally findable as long as you're looking there when you scroll. We can maybe catch eccentric thickening here that's more subtle. You can catch webs if you're looking. But the problem is many chronic PEs are hard. You know, this medium-sized vessel going to a tiny one, that's a chronic PE. If you're not staring at that while you scroll, like good luck, right? Or is this vessel the same size as one about the same distance? Very tough call. Chronic PEs get very tough for CT sometimes, and this is where other findings can help, like is it causing mosaic perfusion? Now the classic teaching, I love this because it made so much sense to me when I learned it, was that vascular and airways causes of mosaic attenuation should look different. Theoretically, vascular should be peripheral, where PEs get lodged. Airways is everywhere. And vascular could be small or big areas that are blocked, whereas airways should be secondary lobules and always sort of be this homogeneous size. I loved this. It made so much sense to me. I love the physiology. And in real life, every single case is in between those two. So I don't know, not that helpful, but look, I'm still teaching it because it isn't fun. All right, last one, controversies in the area of PEs. We have a couple. Instead of reading them, let's dive in. The biggest is, are we overdiagnosing? Here's a paper from a very well-respected journal, and this is the kind of criticisms I like to get. Ooh, your test and you are just so good. It's a problem. So are we so amazing at finding PEs that we're finding ones we don't need? You know, the concept is evolutionarily our lungs maybe were supposed to filter out PEs. And there is some evidence that the tiny ones, if you don't treat like they couldn't be anticoagulated, they're okay. The other thing is we've been finding way more PEs with better scans, better tests, and actually we're not saving more lives than we did like 2 decades ago. So we might be finding too many tiny ones. There are some good recommendations like, hey, let's make sure we actually think they have a PE first. I know I'm saying this and your ED's not going to do it, but it makes you wonder. They've said this, it's weird. Hey, have you ever just thought about getting a crappier test? And it doesn't seem very like how our hospitals work, but that's an interesting idea. But how about this one instead? Let's just find what's there, and then you can figure out what to do with it. I mean, how hard is it? Do a study. And I think it is somewhat relevant to us. This was actually a quiz question put out there. It was surveyed a bunch of radiologists. What is the next treatment for an isolated subsegmental PE? Should our colleagues always treat? Just treat if the person's in tough shape? Do we figure out if they're likely to get more? Maybe do an ultrasound? Or are we supposed to say totally irrelevant? What's the right answer? Yeah, so it's C. Are they actually likely to get more? And then maybe let's do an ultrasound and see if they have a reserve. And the idea, a reserve of clot. And the idea here is if someone is healthy enough and doesn't have a likely source of more PEs, maybe you don't have to treat. So what does that mean, unlikely to get more? They're not in bed, they don't have a line, no AFib, they don't have a reserve of clots somewhere else, okay? Now, some people say if we're going to do this, you have to keep getting many, many ultrasounds. That sounds very expensive. So I'm not sure that's really what happens. And in fact, the most recent high-level paper I've seen on this actually said, there's still not high-quality data that we should or should not treat subsegmental PEs the same or different. So I don't actually know. I think it's still controversial. I know I feel bad when I find a teeny tiny one, and I sometimes call them and I'll be like, oh, gosh, I found a teeny tiny one. Sorry to ruin your day. But I know in your literature, sometimes you don't treat it. Okay, good luck, bye. And they can figure it out. All right. People like to talk about other modalities in PEs. VQ, I actually trained in nukes as well, believe it or not. And I know my colleagues, and they're like, ooh, VQ is the gold standard, has been since 1972. So I get the concept, but it's probably not, right? We know in real life, CT is sort of one here. The issue is that we do some VQs, though. Contrast allergies, radiation sometimes. We'll talk about it, chronic PE. And the chronic PE thing surprises people, but VQ probably does find slightly more chronic PE because in CT it can be hard, like I showed you. We actually don't overcall stuff because you can't really see anything. Interestingly, SPECT does not make it better, probably because the 3D is just harder to read. So VQ is actually slightly better than CT. There is some confusion as conventional angio, like our standard. This was a point of an early CT study. I actually think sort of professionally growing up in the CT era, that's a very hard thing to read, a three-dimensional lung smushed into two dimensions. Is it really the gold standard? Probably not, given how invasive it is, and obviously not used much. When we had old scanners, people said maybe there was a role for ultrasound. Not these days, but certainly it's reasonable if you want to do an ultrasound first, if it's a clot, if you'll treat it, if we'll just move on with life, sure. But it doesn't rule out PE, obviously. So it's not like ultrasound replaces CT. A big question, especially during this contrast issue we had a year or two ago, is whether or not MR can take over. We did actually study this years ago in PIOPED 3, that was the point, and said, hey, we find a reasonable number of PEs. How did we get that reasonable data? By throwing away the 25% of studies that look like trash. That's how I want to do research. Like, oh, those were terrible, but look at the rest, they're amazing. We just can't find PEs with MR, right? Yes, it's getting better, but we're not quite there. It's obviously way more expensive, and there's a lot of scans out there. So we don't really find the small ones yet, not standard. What is close to standard, though, is dual energy, and the idea being we can get these virtual, beautiful monochromatic images. I was actually very underwhelmed until I had this case, and I said, oh, gosh, I don't know, is that real? It looks terrible. It's like, oh my God, the dual energy, that's the point. And then yes, really great pictures, enough for me to be sure. So that's when I became a convert. These make better pictures, and you can do it with less radiation or less contrast. I'm pretty sure we'll all be doing studies like this in the future. The iodine map, though, I think is much harder. Yes, it can find some clots, but you have to read it in this sort of three-dimensional way. Maybe we'll use it for chronic PE, But for acute PE, it just does not help enough and is too much work to read. Radiation is one topic. I'm from Denver. I get more radiated than we do in most places like here. And the big issue is actually VQ is okay. It's that there's more with CT, particularly the breast dose. So for young women, maybe we shouldn't be doing CT. And where I really find the question is, and this is the very last point, is in pregnancy, people ask about it a lot. So many recommendations out there, like maybe do an ultrasound first, look for a pneumonia. But what people care about is the fetal radiation. It is actually slightly better with VQ than CT, and particularly when it comes to the breast dose for the woman that's carrying. So it really makes you wonder. Many of us then have a sort of discussion around this. We say, well, do we do CT more? Should we do a VQ? CT certainly gives us more answers, and I've always said that there's no definite conclusion out there in the literature. But there actually was a conclusion out in the literature that eventually came out 7 years ago. What do we do in pregnant cases? And here's what they said. They said if your pregnant patient has a leg symptom, which don't they all, they're pregnant, it says you can do ultrasound and VQ and maybe a CT. And if there's no leg symptoms, you can do a VQ and a CT and maybe an ultrasound. So we're going to go back to who really knows, but I think CT usually wins. All right, so we went through imaging assessment, pitfalls, findings, and controversies, and the big goal is not to overcall. Thank you very much.